Welcome to the Healthy You podcast from North Shore University Health System, where we tackle trending topics in healthcare. Did you ever wonder why a medication works well for one person and for another seems to have no benefit at all? It can be extremely frustrating to patients and caregivers alike when this happens. I'm Andy Buchanan, and today on the Healthy You podcast, we're exploring pharmacogenomics, which is trying to solve this problem by examining patients' DNA.
And for that patient, it's empowering because they begin to understand it wasn't something that they did wrong that made that medication not work. It was something that they inherited from their mom and their dad.
Pharmacogenomics is a form of personalized medicine, which involves customizing a patient's care and treatment plan based on their unique genetic characteristics and health history. It's been called by some the next revolution in medicine, but how exactly does it work? Who can benefit from it, and in what areas is it having the greatest impact? We're going to be talking to an expert in pharmacogenomics who can help answer these questions.
I'm Mark Dunnenberger. I'm Director of Pharmacogenomics here at North Shore in the Mark R. Neiman Center for Personalized Medicine.
So, pharmacogenomics, that's a made-up word, right? You made that up with your buddies? Or?
Yeah, actually, so pharmacogenomics is an incredibly interesting history as a word. It's actually been around since the 1950s, which catches most people off guard. You would think it's like something from the 90s or the 2000s or maybe the last couple of years because it's the first time you've heard it, but it's actually been around for a very long time. But what we've been able to do recently is figure out what does it mean to put it in clinical practice? What does it mean to use pharmacogenomics in a way that it impacts a patient's care and it improves patient lives? And so that's what we've been doing here at North Shore. But ultimately, what is it? It's as simple as taking some genomic information about you, so some information from your DNA that you got from your mom and your dad, and put that in context of your drugs that you have received, are currently taking, and may take in the future to help reduce the amount of trial and error medicine and hopefully pick safer, more effective medications for you as we move forward in improving your health outcomes. So one of the common catchphrases for this, so like the short answer of that really long one I just gave you, is the right medication at the right time, at the right dose for the right person. A 13-year-old female that came into our clinic with her mom, she'd been diagnosed with depression and anxiety, the daughter, the 13-year-old. And for 18 months, they had been trying to figure out which medication was going to work for this young girl. It had gotten so extreme that the mom talked to me about having to give her daughter poison every night. And it wasn't that the mom was doing something mischievous. It was those antidepressants that were being prescribed for her were not working, were causing side effects, and the mom really saw them as poison. They weren't helping her anymore. And so clearly there's a problem there. For those 18 months, they had tried 6 different medications, all very common antidepressants that you might try. It's not unusual to not get it right the first time. If I'm going to treat somebody for depression off the first line therapies, I probably have 15 different drugs to choose from. And I got to pick one. And if we look at the statistics, 30 to 50% of patients are going to fail that first drug that you try. So it really is trial and error medicine. We've got 15 options. We're going to pick one, a coin flip for whether it's going to work, and then we got to switch again. And there's this delay with antidepressants. You have to wait 2, 4, 6, 8 weeks to fully figure out how a patient's going to respond to that. That's why this girl has taken 6 different medications over 18 months. It's not unreasonable to think that's what it took, but in this case, that's exactly what it took. Wow. So those 6 medications. She came into our clinic. We did a multi-gene panel on her. So we looked at 15 genes across her DNA that are related to how her body processes medication. So the pharmacogenomics, if you will. And when we looked at that, there were 3 genes on there that are related to antidepressants. And she actually had a variant or a change in every one of those genes. And so as we looked at the antidepressants that they had tried, there was a genetic reason for that not to be a great choice for her. And so we were able to begin to piece together that story of, well, these 6 medications that you've just tried for the last 18 months that haven't worked for you, here's the genetics to explain why that happened. And so what that allowed us to do is then say, okay, with this information going forward, with what you've already done, here are 3 medications that we think might be a good option for you. We went and talked to her treating physician on this. The treating physician tried one of those medications, and it didn't work. They tried a second medication, and the patient's been stable on that medication for over 2 years now.
Wow.
So again, wasn't a crystal ball. We didn't get it exactly right, but we've really cut back on that trial and error. And we were able to narrow it down to 3, got it right, and now this patient's doing quite well.
That's a great example. So do you have others where pharmacogenomics is applied? You've talked about mental health, but I assume there are many other areas as well.
Yeah, so pharmacogenomics can be used with some antihypertensive or high blood pressure medications. It can be used for some blood thinners, most notably Plavix or warfarin. It can help pick either the dose or the drug we're going to choose in either of those settings. We can also use it for pain management. And then for some patients, you actually end up doing a multi-gene panel and using the information over a couple of different disease states. So another case that we had come into the clinic, this was a 68-year-old male, and he had had previous surgeries and had had some difficulty with pain management in those previous surgeries. And he was getting ready to come in for a hip replacement. And during the hip replacement, he was worried about his pain management. But he also was going to need some blood thinning because he was not going to be mobile for a little bit. And so they were going to prescribe warfarin to go along with it. And because we did a multi-gene panel, we were able to get some information about his pain management as well as what dose of warfarin he needed. So he actually needed a lower dose of warfarin, about half of what you would have otherwise expect. So we helped reduce his bleeding risk by getting him a more appropriate dose up front. And in the pain management setting, there wasn't a strong signal that there was something different about his genetics, but we did get a little bit of a signal that said he might need a little higher dose than we'd otherwise expect. And so there, up front, the clinicians didn't do anything differently. They just used this information to have a lower threshold for going up on the dose if he was going to have pain. It turns out that he was able to handle the normal dosing of the medication. But we had that information if we needed to use it. We didn't have to wait till he had the problem and then do the genetic test. We did it preemptively or upfront. And this is where pharmacogenomics is moving and genetics as a whole, is how do we get into preventative, proactive, preemptive care of patients? How can we gather the information ahead of time and then turn it into knowledge when we're taking care of our patients at our bedside?
I had dental work a couple years ago and ended up just in tremendous pain. It kind of went wrong, and they were giving me Vicodin, and it was doing nothing. And it was obviously very frustrating. So that's something maybe if I had had a pharmacogenomics test that could have possibly benefited me.
Yeah, definitely. It potentially could have helped you. So Vicodin, the medication you just spoke about, it has to be, it undergoes some chemical changes in the body. And the proteins or the pathway that that chemical change occurs under is something where we have variation in the population. So some people can do that process very, very well. They're called ultra rapid metabolizers. And some people do that really, really poorly, and they're called poor metabolizers. And there are people in the middle, like normal metabolizers or the average patient. And so based on your story, I might guess that you're a CYP2D6 poor metabolizer. Or you might have another variation in a different gene, but I'd be incredibly interested to test you and see what your genetics says.
Nice. All right. When we're done here. Right now, though, it seems like we're focusing on people who have an acute issue as opposed to just offering it to the general population.
So at North Shore, anybody can get it at any time that they want it. And in fact, we have a good percentage of patients who are completely healthy individuals that are in their 40s and 50s that get this test done so they can have the information embedded in their medical record to be used if something happened where they would need it. And so that's getting more and again into that preemptive, preventative, proactive medicine approach that is kind of core to personalized medicine here at North Shore. And our patient population is really buying into that.
Do they seem to be embracing it, or what is the feedback you've heard?
We have a very robust clinic and a nice testing platform where we have ongoing interest in the testing. I think some things that are really interesting are the cases and stories we get from patients where before we started doing this in clinical care, I would have said, I'm not sure there's value in testing this particular patient. So one example there is somebody who has failed multiple antidepressants. And when you ask the doctor, what are you going to do next? She's like, I'm not really sure. I think maybe we're going to use non-drug oriented approaches. Well, pharmacogenomics is about getting genomic data to help you use drugs. And if you're not going to use drugs, well, I'm not sure pharmacogenomics can be helpful for this patient. But we've tested those patients, and then we talk to them, and we find out that there's some genetic variation they had that explained why they failed some of those other drug therapies. And for that patient, it's empowering because they begin to understand it wasn't something that they did wrong that made that medication not work. It was something that they inherited from their mom and their dad. And so it's valuable to them in that setting. And without doing pharmacogenomics in clinical practice, I would have never have guessed that there was real value in that case. But I can tell you, I can sit across the table from a patient and see that there's real value in those cases. So plenty happy to test those particular patients. Another thing that our patients have told us through some studies that we've done is they're actually more confident in their prescriber and more likely to take their medications if they have pharmacogenomic data available. So it may not be that we use the pharmacogenomics to pick their medication because maybe they were being treated for something that wasn't related to pharmacogenomics, but they had it if they needed it. That makes them more confident in their prescriber and then more likely to take their medications. And getting patients to take their medications is probably the most important thing about drug therapy. Mm-hmm. If you're not going to take your medication, I can tell you something's going to happen. And that is that drug's not going to work for you. That's right. Concrete. That's definitely there. So if we're using pharmacogenomics to increase adherence, I think that's an incredibly powerful thing. And we're beginning to see signals of that.
Yeah. 23andMe and these kind of over-the-counter genetic tests have really become super popular.
Yeah, so direct-to-consumer testing is becoming more and more common. 23andMe actually, in late November, early December, I got FDA approval for a pharmacogenomics product. So they will do some testing on you and then give you a medication profile. The problem about those types of tests are sometimes they don't go deep enough. They don't interrogate enough of the variation that might be out there. They might not look at enough places in the DNA to get a real meaningful answer or a complete answer. And so I wouldn't necessarily use those in clinical testing or in a clinical situation, but I think they're a great way to begin the conversation about personalized medicine, about how genetics might affect drugs, and get the patient more engaged in taking care of themselves. And that might bring them into our pharmacogenomics clinic, where I can have a much more robust discussion with the patient, really talk about the benefits, limitations, and risk, and we can make a value-based decision for that individual, that patient sitting in front of me, about whether we should go forward with pharmacogenomics. So I love it from the educational standpoint, not so crazy about it from the clinical implementation perspective.
Yeah. Going back to what you said at the beginning about pharmacogenomics and that it actually came up in the 1950s, you said? And so can you talk a little bit about that? Like how did it, they weren't analyzing people's DNA back then, were they? And
so they knew that genetic variation existed, right? We've known that for many, many years. Mendel and the pea plants and those things from your high school biology class, those have been around for a long time. So they began to get the sense that genetics played a role. There are quotes from ancient Greek doctors about, we know that there's variation in how patients respond to medication. So the idea that you can give the same medication to two patients to get two different responses has been around for thousands of years. Mm-hmm. So the idea of what we're trying to tackle is out there, and it's been true. In the 50s, we started thinking about what it might be and how genetics might play a role. And then in the 90s, we started doing single gene tests and understood in some places very significant differences in DNA that we could do something about. And then in the 2000s, it got a little more broad. And then in the early 2010s to where we are today, we've really started to see some robust implementations, but a lot of them have been focused in the research setting versus here at North Shore, really focused on real world experience in the clinical setting. What happens when we put this data out there? How do we activate it? How do we make a difference in a patient's life with this data through routine care and not make it something special? Make it the healthcare of the future today.
I know you were expecting this question, but is pharmacogenomics covered by insurance, and how much does it cost if it isn't?
Yeah. So,
or is that a moving target? Or
yeah, this question we get it all the time, right? Every patient wants to know, how much is it going to cost me? What does this mean for me? So for insurance, depending on the indication, so the reason that you're getting pharmacogenomic testing done and your particular insurance plan, it may be covered. It's variable, to say the least, but it may be covered, and it's worth asking your insurance company before you do pharmacogenomic testing, is it going to be covered? And you're going to have to contact the lab, whoever's doing the testing for you, to get some information to find out that answer. But here at North Shore, we just went to a new price of $125. It's the out-of-pocket cost of it. And you can then, we give you an itemized bill and you can submit that to the insurance and maybe they'll cover it. But the max you're going to pay is $125. Pretty excited about that change. It just happened real recently.
So I have read some skepticism in the press of maybe not as much pharmacogenomics, but of personalized medicine, and saying that it's maybe being oversold a little bit. And I guess I'm just wondering what your reaction is to that.
Pharmacogenomics is not, on average, going to tell you, here's the one medication that will solve all of your problems at this dose, and if you take it at this time of day, everything's going to be fine. You'll never have another problem in your life. It's just not going to do that. Talk to any healthcare provider, talk to any patient, they know healthcare is complicated. They know taking care of patients is complicated, and one piece of data isn't going to explain everything. And we have to face that when it comes to personalized medicine and to genomically informed medicine. We need not to oversell it, because then that puts us in a little bit of a disadvantage. We need to own up for what it can do and what it can do really well. And then we have to surround that information or that data with a system that can activate it and make something happen from it. So you could go somewhere and get a pharmacogenomics test, get the results, and put them in a paper report or a PDF. Just sit there. Nobody ever looks at it. It doesn't help you, right? Just doing the test doesn't have intrinsic value. You have to do something with it. If you're at a health system like at North Shore, where we've integrated into the medical record and are able to present it to the provider at the right moment with the right context around it, you're really going to begin to make a difference in a patient's life and somebody's prescriptions in terms of pharmacogenomics. So you've got to really couch personalized medicine around all of those things. It's more than just testing. It's about data activation and, more importantly, about patient activation, right? If you think about letting patients know that we looked at this and this made them more confident in their prescribers, more likely to take their medications, well, what is it? That's activating the patient and the family to be empowered in their healthcare and do something different than they otherwise would, hopefully leading to a good outcome. And that's really where we're headed. How do we take data? We're getting more and more of it every day. How do we turn it into this thing that can help people and be activating?
Are there really interesting developments coming down the pike that you could talk about?
Yeah, so I think when we think about what's coming up in the future, one key point that people need to remember about pharmacogenomics is the DNA that we're looking at. It's what you inherited from your mom and your dad. It's been there since the day you were born. And if I do the same test, the exact same test on you at multiple time points, I'll get the exact same answer. And I can use that answer over and over and over in your care. But testing techniques change. We're able to look at new places. We're able to look at places in different ways. So we're going to have new iterations of tests coming out. Additionally, we learn more about all of those genetic data points. And so we might learn about new drugs. So there's this world where we may need to retest patients. And we're kind of getting at a point where we're beginning to maybe be at an inflection point where we need to retest some patients that we had previously tested. So that's pretty exciting to me because I didn't know how long that was going to take. We're like on the 5-year cut point, and maybe that's what it is. Every 5 years for right now is when it's time to test somebody again. But we've also been changing our knowledge base, learning more about the genetic spots we've already looked at and adding new drugs to that. And so we're constantly putting that into our knowledge base and then having to give that back to our patients. And we're looking at new ways of doing that and new ways of activating the patient into their care. North Shore is about to start a DNA 10K program where we're doing testing not for pharmacogenomic reasons, but the testing includes pharmacogenomic information. And so we're going to extract that out and then utilize that in the patient's care, even though the testing was done for some other reason. And that begins to represent where we're really headed. Let's get all of the genomic information we can have for a patient and then pull out the pieces that we need to pull out when it's valuable to you. And we're about to embark on that journey. And I'm really excited to see how we get there and how we do it successfully.
How did you end up in this field? You talked a little bit about it at the beginning, but you have a degree in pharmacy, but you're not behind the counter at the Walgreens. So where did you change directions there?
So my undergrad degree is in philosophy, so far afield from medicine. And when I got that degree, my parents laughed at me and said, "You'll never find a job." They were kind of right. I don't use my philosophy degree, but I thought I was going to be a teacher, and I knew I wanted to be a teacher. Thought I'd be a college professor, right? And for whatever reason, that didn't work out, but I went to pharmacy school. Well, as a pharmacist, you're a teacher. You're teaching patients, you're teaching physicians about medications all day long. That's your job. You might have to do some other tasks along the way, but your ultimate job is teach people how to use medicines in the best possible way. So I was able to work in Dr. Mary Relling's lab at St. Jude Children's Research Hospital. There, I was able to talk to patients about what their genetics might mean. I went to Western North Carolina, where I'm originally from, did a year of residency, of postgraduate residency in pharmacy practice, and really started to take care of patients in a clinically oriented fashion, rounding on the floors of the hospital, interacting with patients, talking about their medications while they were in the hospital. And right about then was when people started thinking we could implement pharmacogenomics clinically. And so a residency had come up at St. Jude, where I was trained previously, called Clinical Implementation of Pharmacogenomics. That was a perfect fit for me. That took the skills that I learned in the lab and then was able to encompass the clinical pieces that I really enjoyed doing. So I went there for a year. I was their third trainee. There were 2 places in the country to get this type of training. To date, about 20 people have this type of training, 2 years of residency training in pharmacogenomics.
Wow.
And from the skill set I learned at St. Jude, I came to North Shore, and we've been implementing pharmacogenomics since the first day I was here. And we've come a long, long way. And looking back on it, it's amazing what the team here has been able to do over the last 5 years. It's an incredibly empowering place to work at with great resources and great people to work with to do great things. So we have a pharmacogenomics clinic. It's a dedicated pharmacogenomics clinic. You can come to us with test results, without test results. If you're just interested, find out what pharmacogenomics might mean. It's the first of its kind in the Chicagoland area and probably the longest running dedicated multidisciplinary pharmacogenomics clinic in the country. The fact that we get to do that, we have that opportunity, is incredibly rewarding to me, that we're on the cutting edge and pushing the limits of how we can practice medicine today.
So we talked a little bit about the near future, but you're still a pretty young guy. I mean, what do you think we're going to be doing in 2050 in personalized medicine?
Well, we're going to be doing what we're doing today. We're going to be tailoring patients, drug therapies, and treatment plans based off as much data as we possibly can today. We'll be doing that same thing in 2055 and any point in the future. The way we're going to practice healthcare is collect as much information as we possibly can, turn that information into knowledge, activate that knowledge, and take care of patients to the best of our ability. So that's the easy way of answering that question. The hard way is, how are we going to do that? I have no idea, but I'm really excited to find out how we're going to do it.
Well, I want to thank Mark Dunnenberger, the Director of Pharmacogenomics at the Mark R. Niemann Center for Personalized Medicine at North Shore University Health System, for joining us today.
Thanks for those great questions.
Thank you for listening to this episode of the Healthy You podcast from North Shore University Health System. I want to thank Dr. Dunnenberger for taking the time to talk to us, and also thank our producer and editor, John Hillenbrand, for helping put this together. Please continue to tune in to the Healthy You podcast as we explore hot topics in health and medicine.